Good morning and welcome to the final installment of the Follicular Lymphoma Breakfast Briefings from ASH 2021 on Monday, December 13th. I'm your host, Dr. John Leonard. I'm a professor of hematology and medical oncology in the Department of Medicine at Weill Cornell Medicine and New York Presbyterian Hospital in New York. Today we're going to highlight abstract 811. It's entitled Impact of Immunochemotherapy with R-bendamustine or R-CHOP in the post-induction management of treatment-naive advanced stage follicular lymphoma patients, a subset analysis of the FOL-12 trial by the FIL, basically the Italian lymphoma group. The presenting author was Stefano Luminari of the University of Modena in Italy. So the FOL-12 study is an interesting trial that basically had patients treated with high tumor burden follicular lymphoma. As you know, the standard therapy for patients with high tumor burden follicular lymphoma tends to be our chemotherapy. We talked yesterday about lenalidomide rituximab, but most patients are treated with rituximab bendamustine or R-CHOP, and that's done pretty much on a physician discretion or an individual patient basis in clinical practice. And this was also chosen in a similar fashion in the FOL-12 study. Now, the primary role of the FOL-12 study was to essentially look at a PET and MRD adapted strategy to the post-induction management of patients with high tumor burden follicular lymphoma. And I would refer you to the recent publication by Dr. Luminari and colleagues in the Journal of Clinical Oncology, where the primary analysis of the FOL-12 study was presented. The main role of that study was to essentially ask the question in patients who were PET negative, MRD negative, in the control arm, should they receive rituximab maintenance with the idea of improving PFS? And in the experimental arm, there was essentially a risk-adapted approach where less therapy was also an option, or at least one arm, in patients who are MRD negative, PET CR achieving patients, with the idea of saying, is that group of patients the ones that can avoid or eliminate rituximab maintenance? And the net of that trial, which you can again see in the JCO, was that if your goal is improving PFS, you should basically just treat everybody with rituximab maintenance. And by reducing therapy in those PET negative CR patients, MRD negative patients, you're going to essentially have a shorter PFS. And that's not surprising. If you give more of a therapy in a group of patients where the therapy worked, you'll have a better outcome, at least with regard to PFS. Now, importantly, PFS was changed, but overall survival was similar. So the subset analysis that's being presented at ASH 2021 is focused on the chemotherapy question. As I mentioned before, R-bendamustine and R-CHOP have been used in different scenarios, and this was essentially something that was up to the discretion of the treating physician in practice. Clinically, we make our choices in consultation with the patient and the clinical scenario. And in the FOL-12 study, the question being asked here is, were the findings in the two arms, basically automatic rituximab maintenance or a rituximab maintenance only in patients or evaluated in patients who had MRD negative CRs? Did the choice of chemotherapy really impact whether or not the strategy should be different? And the net here is that, as you know, generally speaking, R-bendamustine and R-CHOP have similar PFS. The neutropenia was less common in rituximab bendamustine. That's been looked at before. R-bendamustine also had different infections and rashes, had more rashes. But at the end of the day, the substantive findings of the FOL-12 study were similar, regardless of the chemotherapy. PFS was improved in the standard maintenance arm, whether or not you had R-CHOP or R-bendamustine, and the adaptive arm did less well with regard to PFS. with regard to median follow-up 56 months. So I think this tells you that the lessons of the Fall 12 study are irrespective of which chemotherapy you use. If your goal is PFS, rituximab maintenance has benefit. But again, if your goal is overall survival, you can really tailor your choice on an individual patient basis. I want to thank you for joining me for follicular lymphoma breakfast briefings from ASH 2021. I know that many people were attending the conference in person, but many also, for obvious reasons in the pandemic, attended remotely. Hopefully next year, everyone can be here in person. But despite being partially virtual, it really was an excellent meeting with a lot of great new information, and we've enjoyed discussing it with you. If you or our colleague missed the festivities and like to share the videos, check out the archived follicular lymphoma breakfast briefings on the Oncology Education Hub at cmeoutfitters.com. Thanks again for joining me for ASH 2021, and best wishes for the coming year.